Hey everyone, welcome back to my channel, and if you're new here, I'm Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Simon Simonsen, and he's going to talk about MDT and chronic pain. Simon is a physical therapist with 25 years of experience, McKenzie diplomat, and an instructor at the McKenzie Institute International since 2010. Simon has a private clinic in Denmark, and before that, he worked at the country's largest interdisciplinary pain clinic for 8 years. I hope you enjoyed the show. Hi Simon, welcome to PT Pro Talk. How are you today?
Fine, thank you. Autumn has set in, so today is a gray day in Denmark, but well, that's fine. It's that season. Yeah.
Awesome. And here's just early in the morning. So let's just get started talking a little bit about yourself and your background for the ones that don't know you.
Yeah. I qualified as a physical therapist in 1997, so that's 25 years ago. And within a couple of years, I got interested in MDT as a good way of getting people to do more themselves and empowering people to take care of their own problems. When I qualified, we were mostly trained in passive modalities and told that, you can throw in some exercises if you want. So when I got into MDT, that kind of linked it together with the manual therapy and the active components of the treatment and getting people self-involved. So I did my credential in 2001 and started doing my diploma in 2003, and I finished my diploma in 2004. Did my residential part of it in Austin, Texas. So that was pretty cool to go abroad and get a feel for how things are working outside Denmark. And I think in 2008 I started teaching on the postgraduate courses in the McKenzie Institute in Denmark. And along the way, I've been working private practice most of my life, for my time as a physio. But in 2012, I switched to work at a hospital on a chronic pain clinic that was a multidisciplinary pain clinic. So we worked with nurses and doctors and social workers and psychologists and secretaries and so on, where we both did individual assessment and treatment plans, but also pain management classes with psychologists or social workers, where we had groups where we taught them how to manage their pain and how to get the best of their life with a chronic pain condition. And then in 2015, I opened up my own clinic in the city where I live, private practice. And that just turned 7 years yesterday.
Oh, congratulations.
So thank you.
Awesome.
And in that clinic, I mainly see patients with back problems, like herniated disc, lumbar prolapses, neck problems, headache, and people with long-standing multiple pain areas, chronic pain type of patients. So I see some of those, and that's mainly based on the work that I did at the pain clinic.
Awesome. So how different when you first started just passive? That's crazy how things change
there was
over
a lot
time.
of ultrasound and shortwave and heat and massage and very little active. I remember one of the things that actually got me interested in MDT was that patients asked me, well, is there some exercises that I can do at home? And I was like, I don't know. So I really hated that question, but as I got into more and more MDT, kind of made sense that way.
Yeah. Now you can give them the exercises to do at home for sure. So you have a big experience with chronic pain, and that's what we're gonna talk about here today. So how are the MDT classifications in the chronic pain population?
Well, when I started at the pain clinic, I decided to kind of make statistics on that patient population. The population we saw at the multidisciplinary pain clinic was kind of like a last chance clinic. So if let's say you came as a patient to the clinic and have you seen maybe some different specialists, you've seen some physios, you've seen some chiros, you've been to rheumatologists, and the doctors kind of took an overview and said, well, you haven't really been to a neurologist, or you haven't been to this specialist, so you need to go there first to see if they can fix you. And if they couldn't, then you could come back. So it's kind of like when they got to the clinic, all other options for them to get cured were already tried. So if that wasn't tried, they weren't allowed in. So we really had the one where the chronic pain had a major impact of all aspects of their lives. So when I started doing initial assessments of them, I decided to keep tabs on how does it fit the MDT classification and what else could we do. And at that time when I started, central sensitization was really just the thing. So we got into the central sensitization inventory, and I did my MDT assessment, and I kept tabs of it for 436 consecutive patients that I saw at the clinic. And this is the initial eval. So if I identified a directional preference, they got classified as derangement. If they fulfilled the criteria for mechanical dysfunction, they were classified as dysfunction. And if they didn't fill that criteria and they tested positive on the screening for central sensitization, they got classified as sensitizations. That's a difficult word. Central sensitization, yeah. And then there was the other group where we knew what was going on, and the mechanical evaluation fit that profile. For instance, spinal canal stenosis, where you said, well, worse with everything that compresses, and relief with everything where you take off the compression of the nerve, but no overall change. So if it fit that would be in the other category. And the last category I did was inconclusive. And for some of them, the first time, all you actually got to hear was their story and their history. So even though we had 1 hour and 20 minutes for initial eval, sometimes we didn't get to do any assessment on them. So that would be an inconclusive. And sometimes if we did the assessment, they didn't fit the derangement syndrome, they didn't fit dysfunction, there were no signs of central sensitization, and they had no other known pathology that could explain why it behaved like that. So that was the inconclusive. And the derangement group was about 30% of them. The central sensitization were about 20, and the other group was about 20, and then the inconclusive was almost the rest. As I remember it, I think about only 3% of the patient were classified as dysfunction. So that was a minor group. So actually, despite that being in this group where a lot of things had been tried, almost a third of them did display a directional preference.
Yeah, that's a big number, considering that they passed through all this type of treatments and they're still derangements.
And some of them actually got rid of their pain. So some of them became pain-free, but for a large number of them, it's more like, well, they did the directional preference exercises that then they could get to a certain point where the pain was more manageable, but they didn't become completely pain-free. Also in the clinic, we were limited by how many treatments we could see them, and that we covered a very huge area. So it was difficult for people some of them had to travel by car 2 to 3 hours to get to the clinic. So some of them, because of that, kind of dropped out, and we tried to see if we can find some clinicians in the area where they live that could continue with the treatment or the treatment plan. So we didn't have the possibility to actually follow all of them through. That could have been nice, but that wasn't an option for us. And also, it wasn't the pain clinic was kind of put in the world to help people manage their pain. So if we found something that seemed to be able to relieve them of the pain or cure them, we should just get them back out into private practice and let the physios out there with some direct say, well, we found this and you should work with this.
Yeah. What a tough position to be in. You just get the ones that have no
Actually,
clue of what's going on, and nobody knows what to do with them, so they send them to you.
Well, I mean, I think in my early days I would have looked at it, but now I like to work with chronics because a lot of them have tried a lot of different stuff. So there's two possibilities. Either you can help them, and that really put you on a pedestal, and they'll be really pleased, and obvious, so will I. Or you're just like the rest. You're just the next in the norm, and you can try instead of trying to have a focus on fixing your pain, let us see how you can cope with it and how we can get a better life. And for some, if they start focusing on fixing the pain and start focusing on living with the pain, actually the pain's impact on their life becomes less. So basically they get less pain, not because any exercises or mobilization or anything we do, but just have a look at the whole picture and say, well, if we kind of structure the way you do things differently, you get a better life.
Is their expectation? So they're not expecting to be cured or fixed. They just expecting to learn how to cope.
Well, some of them thought that. I come to the pain clinic and they have the magic pill that no other doctors have, which is obvious. Or now they came to see the physio and he has the magic exercise that no one else has. Well, for some of them that displayed a directional preference, it did appear like that. But for most of them, I mean, 1/3 did display directional preference, but for the rest of them, we were back to, well, this is how you need to work with this and this is how you need to cope.
Yeah. And I think I missed the inconclusive. What was the percentage of the inconclusive that you found?
About 1/4, 25%.
Okay. And then if they're inconclusive, what were the criteria?
The criteria was that they didn't display the directional preference. They didn't fit the criteria for dysfunction. The screening for central sensitization didn't display that. And they had no known pathology that could explain why they behaved as they did. So if we did the assessment, they ended up in that group. And also one of the others that did was after the first eval, some of them, just needed to tell their story, and for some it took long. So sometimes the first time was just hearing their story, so we didn't actually get to the physical examination. That was I also put them in the group of what do you call it? Inconclusive.
Inconclusive. Okay.
Yeah.
Awesome. So then what do you do? What is the management for each group? Like, we know the arrangement, dysfunction, but like I'm interested on learning what would be your approach on the other groups that are not easy resolved.
Well, some of them got into pain management groups, which was a big part of it. And one of the interesting things I found about the MDT approach to testing is that you could, some of the signs about central sensitization is that people get flare-ups where they say, well, I didn't do anything, but the pain got really bad, or they have a latent pain response. So it's kind of like if they do something today, when they rest or the day after, they get really excruciating pain. So we used MDT assessment to test that, and my experience was that usually it would take maybe 5 to 10 end range movements where you get all the way to end range. If you did 5 or 10 of them, they would get a flare up. And that's one of the ways where we talked about it with the patients. Well, you get these flare ups. We need to figure out how much you can do. And then we tested them, and if they got that flare up, we said, well, how long time do you think it'll take before it goes away? or it's settling down again. And they said, well, maybe 2 or 3 days, and said, well, we'll reschedule, and next time we won't do as much, but we'll try to work into where is that limit. And usually we would go about saying, let's say you need to vacuum your house. That's one of the things we say, well, bending forward, if we do that 10 times, you get a flare up. So we started just remodeling how much, well, you can do 1 flexion in lying. Okay, if that's okay, tomorrow you do 2, and you do the next day you do 3, and you just got a gradual exposure to it to figure out how much, where's the tolerance, work below the tolerance, and then slowly build it up every 2 to 3 weeks. So that would, in crude words, that would be the approach. Finding out where the tolerance is and just work just below it.
And the criteria, just you mentioned about the criteria being doing repetitive movements and they having a flaring up the condition. Any other criteria that you use to classify as central sensitization?
There's the central sensitization inventory, which is a questionnaire of 25 questions, and you score them. And if they have a score above, can't remember anymore, but you can score a max of 100, and you have you have a score above a certain point. So at each initial eval, they scored that as the first, and then when we did the testing, if they displayed that and they got those flare up, they would be put in that group.
Okay.
Because central sensitization, there's not really any clinical test that we can do 100% in the clinic that just say, well, this is it. So it's more like they'll put in we suspect this is what's going on.
Mm-hmm. Okay. That's interesting. And then how about the others?
Well, if they, let's say...
How do you manage?
That depends on, let's say you have someone, we did see quite a large group of lumbar stenosis and also cervicals. So it's kind of like, well, you can do we tested out flexion, can it give them some relief? And if we do it aggressively, can they get to a point where their tolerance to what extension activities would get better? So that would be some of it. And then, showing them, well, this is why this is happening, and this is what you can work on doing to see if you can increase your tolerance for normal activity. While I was there, I was in a working group in the National Danish Health Board, where we did clinical guidelines for lumbar stenosis for people over the age of 75. So we went through the literature, and there's no exercise-wise, there's some benefits with general exercise, but not precisely towards their symptom, but it's more like a health benefit. So it's not like you can say, well, if you do 10 squats every day, your lumbar stenosis will go away. So a lot of it was try to educate people about how do you rest your nervous system, and what should you avoid doing for a prolonged period, and how should you try to build up tolerance, because they have all those we saw had either been assessed for surgery and the surgeon said, well, we can't do it, or they had surgery once or twice, but it didn't relieve the symptoms. So it's a managing thing.
Mm-hmm. So that would be general exercises and
a focus on relieving pressure on the nerve. So typically they would get flexion exercises at home. Also, we saw some with rheumatoid diseases, where it's kind of like, well, if it's active, this is what you should do. If it's inactive, you can do more of this. And so it's an educational approach to getting people to understand their condition better in order to handle it better.
Mm-hmm. I was just gonna ask you about still on the other, what other type of problems, diagnoses that you saw, and how did you manage them? That was the question.
Yeah, and also some of the things that we saw also quite a lot was lumbar fusion, and I think when I look at managing those, I think those are the ones that had the toughest symptoms to actually do anything about, because the lumbar spine is fixed and it's still hurting, so you can't really move it and you can't find any position that relieves it. So those were some of the patients. Some of them got quite good relief from pain medication, because the doctors at the clinic were really good at combining medicine. But from a physical therapist point of view, we didn't have much success with them.
Yeah, I find that they are a tough group too, because they just don't respond as well as the other normal lumbar pain. So it's a tough one. And did you see them ending up like taking out all the screws and all of that, or they just stay like that?
Well, we had them. I can't remember anyone who got their screws taken out. Maybe some of them did, but not that I would be aware of.
Yeah, I saw some cases that people would go back. Not in the US though, in Brazil, because I think things are different. In the US, it's just so common. I guess a lot of people have back pain. Let's go do a fusion. But I've seen people in Brazil not finding solution for the pain, and when going back and taking them out and then getting better.
Well, in Denmark at the moment, there's quite a stir about the lumbar fusion, because it seems that a lot of patients have had them, and lumbar fusion can be quite good for leg pain, but the research shows that it's ineffective for lumbar pain. I do know from my time in the US that people get surgery for things in the US that we would never consider being surgical candidates in Denmark. So there's definitely a cultural difference. If you look at the research, as I understand it, lumbar fusion, it doesn't really have any effect on lumbar pain. If it does anything, it makes it worse.
Why people do it then? Right. Oh.
If you get a patient that said, do something, and that's the only option left, I think that's some of it. But I asked myself that question. Yeah, I had some patients in my time in Austin where, even though they displayed directional preference and they got really much better, they still got having nerve blocks and surgery, and I was kind of like, but why? And that was a cultural difference, because we wouldn't do that in Denmark, but it happened more often in the US.
Yep. Last month I had a young patient that had hip pain for 3 months, and she was ready for the surgery. She's doing the pre-op to do a hip replacement. It's just unbelievable. Okay, let's focus on our others. What else? Any other diagnoses that you want to mention?
Yeah, I think that's those would be the main ones. We also had some. We did get some amputees, but they did. Most of them did end up in the central sensitization group.
Okay, and then how about the inconclusive? How would be the management with them?
Well, I know some of them later on did display directional preference, and some of them, when we did get to make the assessment, did display the other group as well. But most likely it would be pain management, and then try to get to a point where you say, well, if you're overexerting yourself, you need to put in some periods where you rest to give your system a chance to store up some energy. And if you're underexerting, which we also saw, you need to get off the couch and start moving. And then we kind of took them towards that. I think some of the patients did seem to be resting too much because of the pain, and that actually gave them more pain. So there was quite a tough job in getting them. But it hurts when I move, so I don't want to move. Well, but it also hurts when you're lying still. So why are you lying still? But trying to get them, easing them into moving just a little bit more and a little bit more and a little bit more. So that was, they did display the boom bust cycle. Do you know that?
No.
Well, they kind of do a lot, and they push themselves, and then they crash, and then they take 3 or 4 days before it comes back, and then they repeat that cycle, which means they irritate the nervous system and they increase the sensitization, and at the same time they rest so much that they get out of shape and thereby have less tolerance towards movement. So trying to get that to a more stable level. And that was
trying to
that was
find
a
that
lot of work.
balance.
Yeah, that was a lot of the things that we did on the pain management courses, trying to get them through that.
That was gonna be my question. When you say pain management, are you talking about like medication? What, or is that just about trying to find the right level of exercises?
The pain management courses would be 10 weeks if it was a physio and a social worker, and 12 weeks if it was a psychologist and a physiotherapist. With the social workers, our job was basically the same. It's kind of like teaching them about neurophysiology, teaching about central sensitization, and teaching them about getting out of that boom bust cycle, which was most of them we saw. Few of them were fear avoidance. Most of them were boom busters. So getting them out of that cycle and getting into a level where, say, well, on good days you don't do too much, and on bad days you don't rest all the day. So it's kind of trying to get it to a level where it's more stable. So, and if it was social workers, that would be those who were with the work insurance and workers' compensation and didn't really have it together where with the future income, is it retirement, is it working part-time, how to structure all that. And there's a lot of rules and regulations about that in Denmark. So the social worker kind of did that, and if they were going back to work, they did a kind of like a back to work schedule where they said, well, you start out this week on 2 hours, and then we increase it slowly over time and see how much you can do. What the psychologists did with those who were more clear on the income side, on the social side, and it was more if they were really fixed on ideas. Well, I'm not a good mom if my house isn't completely clean, or I'm not a real man if I don't mow my own lawn by hand, or whatever it could be. So it's kind of like getting into that. How do you see yourself, and how do you change that to fit the resources you have because you have chronic pain?
Yeah, that's so interesting. So they were more educational groups. That's very cool.
So we had a 12 session of 2.5 hours where we did every education, or every session had like either mindfulness or a relaxation period, because that was one of the teaching to get the boom busters to start feeling, well, it actually does do something good for me if I have resting periods throughout the day, so I don't get to the end of the day I'm completely wasted and then repeat that cycle next day. And then the educational part, and then group discussion where they came with their problems and we problem solved in the groups.
That's very nice. And how were the results? Did people like those groups? It helped most of them?
Actually, quite. If we look at what happens when you have chronic pain, you usually go through a period where you get pain, and then you're looking for a cure. And if you don't find a cure, you're looking for a cure still, and you go into doctor shopping. And those who entered the group management or the pain management group, if they were still at the doctor shopping, that was a strong predictor that they wouldn't get anything out of it. But interestingly enough, some of them came back maybe a year or a year and a half later and said, well, yeah, I can see why I didn't learn anything, but now I'm ready. So there's a readiness in it. They have to accept that there's no cure and then be willing to work with it. But I think most of them actually took it quite well. And if we looked at the scoreboard where they did it, they used something called the Dolo score, which is looking at biopsychosocial, how does it affect your work, your family life, your leisure time, and you get it kind of like a spider chart where we could see that overall the spider chart got less with those who completed the course. But the one thing that decreased the least was the pain. Some of them said afterwards, well, on the last session, we all talked about that, and before they when they made that score, and someone said, well, my pain level hasn't really changed. but the negative impact the pain has on my life has decreased enormously. And that's basically where you say, well, that's living with pain. Where they don't say, well, I know what to do. Then I do this and I do this and I rest and I get up and I get active and I keep this steady level in my life. And then the pain is still there. And yes, would I love to be rid of? Of course I would. But it's manageable. And some of them, we had one guy, I saw a couple of those, but especially one guy, his pain was stress mediated. So the trigger for his pain was a stress response. So whenever he got stressed, he got pain. And then after the third time we talked about the stress, and the fourth time after we did the mindfulness exercise, the body scan. After that, for the rest of the sessions, he didn't have pain, and he got out of his medication. And then he emailed me maybe a year later and said, "Simon, I'm getting pain. What do you think I should do?" And said, "Have you worked yourself back to saying yes to too much at work and in your spare time? And are you stressed?" And he wrote back to me. He said, "Oh my God, that's it." And then I got another email a couple of weeks later that said, "Well, I went back to my mindfulness exercises and now I'm pain-free again." So for some of them, it worked really well. For the majority, it's kind of like, well, the pain level didn't really go down that much, but the negative impact it had on my life decreased significantly.
That's very interesting, that they can just live better knowing what to do and managing their pain. I know I asked you like managements for like each specific group. Is there anything that you want to talk about on like how can we utilize what we already know or do with those patients? Anything else you want to add on that?
So I think if we look at MDT as was my primary base, and if we look at that, I think it's an excellent testing material to get into where is this patient at. And with some of these chronic patients, you just need to, kind of like we talk about the force progression, you need to regress the force. For some of them, you need to regress it so much that I had some just doing mental exercises like bending forward just seemed to trigger a lot of them. So I got them, and then we said, well, how alert are you of this? And then get them to close the eyes, imagine they're bending forwards, but without doing it. And some of them got an increase in pain doing that. And some of them also, I had them looking at me doing it, and some of them felt uncomfortable watching me doing flexion and standing repeatedly. And if that was the case, we started working on that, saying, well, you have to observe people doing that, or you have to imagine yourself doing that. It's kind of like the graded motor imagery, and you just couple it to, at one point, they start doing physical exercise. But for some of these patients, if the nervous system is that alert and you just try to give them exercises, then you put information into the nervous system and it flares up in the brain and they get the experience that movement is bad. But if you instead of putting information into the nervous system, you get the nervous system to imagine the exercise. So that kind of flares up the motor neurons. And if that elicits pain response, you can also get people to say, well, you can get... I got people who were really fixed on there's something wrong. It's only in my back. I got them to say, well, do this exercise. Try to imagine that you do this and what happens. And they say, well, my back hurts. And then now it hurts more. So I said, well, you weren't moving. So how do you explain that to me? And some of them would go like, well, I tensed up. So, but why did you tense up? Because you weren't moving and you knew you weren't going to move. You just imagined yourself moving. And I also sometimes I just said, well, look at me. And I just did really fast flexion and standing up and down and up and down and up and down. And they would go like, stop that. And say, what? Oh, that's really uncomfortable to look at. I said, but why? Well, it's kind of like my back is tensing up. I said, well, what happens to your back when I'm doing it? And they go like, well, nothing really. So how do you explain that? And for a lot of them, how do you explain that? Kind of was, yeah, that doesn't really make sense. So, and then I gave them if the nervous system is wind up and this is what we need to work at first. So we need to wind down your nervous system, because if we try to get it, and a lot of them would get into better movement, more movement. I remember one woman that was I did maybe educational talk about 30 minutes, and then she had to do flexion and standing. And when I asked her to do it, she kind of just tilted her head down, and I thought she misunderstood me. So I said, "Oh, no, you have to bend your lower spine." She said, "But this is as far as I go." And then she did it 3 times, and she started sweating, and all the color just left her, and she was kind of like, "Oh, I'm going to be faint. I'm going to be." And I laid her down on the bed, and we've just been talking about all this, and she understood it perfectly. And then I just started laughing, because to me it was just so. I mean, it was kind of funny. And she looked at me and said, "Are you laughing?" I said, "Well, we just talked about your nervous system, and you understood it completely, but your nervous system doesn't care. I mean, you did this with your head. That's not even moving your lumbar spine. That's anywhere that would be dangerous to your lumbar spine." And she kind of went, "Oh, okay." So we used the traffic light guide for her, and we said, you need to go to this point where you start sweating and you start to feel really uncomfortable, and you start to feel like you're going to faint. And then you're going to lie down and you're going to let it subside. And then you repeat it 2 or 3 times a day. So she did that, and she came back to me next time and could get as far down as her fingers just above her socks, so maybe 5 centimeters from her ankles. And she was her young son was doing gymnastics, and she was assistant coach, and said, "But how do you work that?" "Well, that's what we call it. I do all the paperwork." And then when I saw her the last time, she came and she said, "Well, my back is kind of sore today because we did the elephant game." Do you know what the elephant game is?
Oh.
It's kind of like with one arm you do the trunk, and with the other you hold your nose, and then you go bend over like an elephant. And you take the hand of the one in front of you. I said, "They've been doing that for 20 minutes. And I said, "So your back is sore? And are you worried about that?" And said, No. I'm telling you this because I'm happy about it. I've never thought I'd be able to do this. And my back is just sore. And I know it hasn't been doing this for years. So it's just like a muscle soreness. And that was because we just started using autonomic responses instead of pain responses. So this is what, she was afraid of those. Instead of saying, "Don't be afraid of them. This is your exercise partner. So you need to go out where that is, and then you need to rest and let it settle down." And the more you do that, it kind of goes like the nurse says, "Ah," and then goes like, "Oh, okay." And then goes, "Are you sure this is good?" And they go, "Oh, okay." And then it's kind of like a graded exposure to fear avoidance. So we did that.
That's crazy. So you just use the traffic lights to help them exercise.
I use the traffic lights for a lot of things with chronic pain patients. A lot of pain patients, if they have a good day, they don't want to talk about it. So if you know a chronic pain patient, you meet them out and say, "How's it going?" They'll be lying, the white lie, saying, "Oh, I'm fine," which is a lie. They're just having one of the not so bad days. But they don't want to say to the people, "Well, today is an okay day," because they don't want to talk about the pain on the good days, which is fair. But the white lie also gives the impression that they are fine. So once they said that 3 or 4 times, and then people said, "So, all right, good to hear that you're fine. When are you going back to work?" And then people go like, the pain patients go like, and start getting a little bit. And then people start thinking, "So you're on social welfare, so my taxes is paying for and you don't want to go back to work. Well, now I like you less." And that's the consequences of the white lie. So one of the things I really tried to get them was to tell the truth, and I used the traffic light guide for that as well. Said, "Well, I have chronic pain, but today is an okay day." And if they don't want to talk about it anymore with people, they just say, "Well, how are you?" And if people insist on talking with them and they don't want to do it, I taught them to say, "Look, I'm really happy that you want to know about it, but this is one of my better days. And today I just want to go out and get some of the life that I don't have on the bad days. But give me a call and I'll make some coffee and you can come over and answer all your questions." And those that are interested, they will give them a call, and those that are not will not. So it's a good way to sort out that too. So that's one of the things that we did with the traffic light guide.
Yeah, very cool. In any other areas that you can incorporate when working with the chronic pain patient? I mean, general exercises? I don't know.
Oh, yeah. Well, I think if you work with a chronic pain patient, I would advise everyone to brush up on their psychology. I learned a lot from working with psychologists to get to that point where you can actually talk with patients about their beliefs and about how they're feeling and about their values and about why they do what they do without them being offended of you trying to tell them what to do. So I learned a lot about, so psychology would be a good idea. General exercises, definitely. There's been some studies that show that there was one study that we referred to for those with fibromyalgia, a study from England where they did 24 sessions of exercise therapy. The first one was 2 minutes on an exercise bike and 23 minutes relaxation on a mat, and then 2 minutes on an exercise bike without any resistance on it, and then 23 minutes relaxation again. And every time they came, they did 1 more minute on the bike and 1 minute less in the relaxation. And then at the end of the program, that was either 2 times a week, 12 weeks or 24 weeks, all of the participants reported increased tolerance towards movement and getting around and decreased pain levels. So I think for some of the chronic pain patients, as physio, we're used to being active, but sometimes I think we just need to, well, maybe just 1 movement today is fine. If that's okay, tomorrow you do too. So it's kind of like getting the starting point so low that you are thinking yourself and the patient is thinking, what good should that do?
Mm-hmm. So I think I heard you saying a lot about like gradual exposure to exercise and movement as they tolerate, using a lot of different tools that you have to try to have them doing a little bit more every time, a lot of education. And the psychology part, do you refer them to like a psychologist, or you just educate yourself to try to, since you are already there with them, help them in that sense?
Both. Working with the psychologist, a lot of, I mean, if they have psychological disorders, that's out of what I can do. But if they have chronic pain patient and they are in a crisis because of that, I understand that well enough I don't need to refer them. But if we do venture into that area more in depth, I usually say to people, I'm not a psychologist, so there may come a time where I say, well, I can't help you with this. You need to see a psychologist. But I'm quite happy to talk with people about the crisis that they're in. For men, it's there was a gender difference. For men, they can't do their work as well as they want to. They can't maintain the exterior of the house as well as they want to. They can't go out with the guys and be one of the guys and just go out and go like, you know, we like to do that, guys. Just go out and just go and just have fun, and we don't talk about anything specific. We just hang out and have fun. And then the sexual part is also important for men. For some of them, they were quite worried about their partner leaving them because they couldn't perform sexually, either because of the medication or because of the pain, or both. So I kind of got that up on my whiteboard and just asked them to these areas, how much do you feel you lost in these areas compared to where you were before? And when we're done, I said, so when you look at this, what do you think? And that was kind of my way of getting them to say, well, I don't think it looked that good. So, okay, well, and then we could talk about, a lot of them were afraid that their spouse would leave them. And I had ways of talking with them about that too. I did a similar thing with the women. That's that work for the women I saw at the pain clinic didn't have so much an impact on their life, so it wasn't so important to them. But that was more of the house, the family, and the friends. So if they lost a lot of that in the social area, that was and for them it was the intimacy with their partner was more. Could we discuss and talk about our feelings? And the sexual part was, well, it's nice if it works, but only if the emotional stuff works as well. I was definitely better at working with the men because some of the women looked at me with that look of, well, you're just a man, aren't you? Which I am. Well, the guys looked at me and thinking, well, you're one of the guys. You're weird, but you're one of the guys.
Yeah, you know what I'm talking about. But I think it makes sense because in the areas you can help them to slowly introduce that back because you are the movement specialist. So it's kind of like combining both of them to learn their biggest fears and helping them to overcome that little by little. So in that sense, it combines perfectly.
So definitely general exercises, but start slow. Maybe down at the mental practice exercise area where you just get people to looking at you doing the exercise or getting them to imagining doing exercises. If they have a really bad day, just don't do anything. Just get out and do your go to the toilet, take a bath, maybe go for a little walk. But the main issue that day is to get more energy. So a good resting plan should be in place. And if you have more stable days, you can start on working towards what do you want to do more? Is it work? Is it leisure time? What are those things that are important for you?
Yeah. So when do you move from mental to exercise? I'm just curious.
Well, usually every time when I had them, I tested. So I would go with as soon as possible.
Mm-hmm.
And if they can get, and for some of them, the transition is quite quick. I have one that I'm seeing at the moment with CRPS, chronic complex regional pain syndrome. And that took us maybe 8 months for getting her from, in the beginning, she would start sweating and her arm would lose color when I sat waving my hand in front of her.
Oh my goodness.
So that's where we started. But now she's lifting weights with that arm. And she also has become a mother, so that's quite good that she can lift the baby. It's still painful, but less than it was. But for most of them, where if they get to that point where they're kind of like, yeah, I can see that. And then you introduce to doing movement, kind of I don't like the word trick movements, but I haven't found a better word for it. So let's say you have one that I use frequently. If you've been told by a lot of physios that you should never bend forward, then you might get fear of flexion. So I get people to sit I get them to go to a squat and put their hands on the floor. And then I tell them to lift their bottom towards the ceiling. And then I say, well, straighten those knees. So it's bottom and it's knees. It's a bottom knee exercise. And when they stand with their hands on the floor and they are almost fully stretched, I take a picture of them. And then I say to them, and then it goes in, oh, so how was that exercise? Well, it wasn't that bad. Well, look at your spine. What's that doing? It's kind of like, well, it's almost fully bent. Yeah. So your spine can actually bend if you don't have focus on it. And then we start working on that. Yeah. So you do it different types of exercises to get it into, to see if it is an obstruction, a mechanical obstruction, that won't work. But if it's not, you can usually get people to say, oh, okay, I can see that. Yeah, maybe I shouldn't be so afraid. And then they start working.
Being creative
Yes.
with your exercises.
Yeah. And get into people's heads. That's the most interesting part.
And you like it.
Definitely. That's the 10 centimeters between the ears are the most interesting part of the human body. And also, if you look at getting people to do exercises, every time you do something, you try to motivate someone. It's not about the exercises; it's about what's between the ears. If you, for those that display the directional preference, the motivation is not. You don't have to do that much because they get an immediate effect and say, "Oh my God, I can see this is working. I'm just going to go away and do that." But for those who are really fear avoidant, you need to work a lot more on that.
Yeah, seems a lot more work, but I'm glad there are people that like it, that are doing it and sharing it, so we are not as afraid of those patients, because at some point you're like, I don't know what to do. So I think it's good to just give us ideas of like how to proceed with those patients that we don't know what to do. Awesome. Anything else that you want to add on the topic before we talk about the masterclass?
No, I think we covered most of it. Be creative and be willing to set the bar so low that you yourself is thinking, and probably also the patient, what good is this going to do? But then persevere and just stay with it and slowly build up. So let's talk about the masterclass.
You may not help the pain, but you're going to help their quality of life, right? So, as you said, so that should be another expectation that you set with the patient.
And for some of them, if they have fear avoidance, you actually do reduce a lot of the pain when you get them out of that. Because if they are fear avoidant, they are just tense. So, and if you have a muscle that's tense all the time, at one point you'll get so irritated it becomes painful.
Yeah. Awesome. Okay. Let's talk about the masterclass then.
Yes. So together with Jane Borghammer and Melissa Kolsky, we've been working on a masterclass, MDT and chronic pain, where a lot of the stuff that I just talked about, we are going to teach it. It's going to be a 3-week online masterclass where we're basically going to do it where we say all the things that you know well from MDT, how do you build on that with this population of the chronic pain, and what are other things that could be worthwhile exploring. And then we do 3 weeks where there's therapeutic alliance, there's psychology, we have graded exposure, and we cover the basis of it. And there will be assignments and both synchronous and asynchronous online versions where you do assignments on the, what do you call it, the whiteboard or the storyboard for the class, and then we do follow up via Zoom or something else like this. So we're going to do that, and it's going to take off in April next year. The first one is probably going to be in Europe, and the reason we take it regional is because of the time, so that everyone can. I mean, if you were in Brazil, you need to get up at 3 a.m. to sit in on a. That's probably not going to work, but we've been working on it during the Corona. It's been quite exciting. Melissa was one of the co-author of A World of Hurt, and I mean she's just a knowledge bank of literature and information. I'm more of the practical guy. I've seen a lot of patients with chronic pain, and Jane has seen a lot of patients also, and is also a member of the faculty of the McKenzie Institute. So it has a huge knowledge about how to make sure that you get a good learning environment, as well as she's been doing a lot of the, what do you call it? She's basically make sure the manual is a good one. Her and Melissa has been working a lot on the manuals. So they're couple of tough women to keep up with, because they're really, really hardworking and they know a lot. So I've been really privileged to be in that group.
Awesome. And you said that is like a 3-week long? Is that right?
Yeah, that's the plan for now. Yeah. So it's
okay.
There's some of the lessons you can assess online whenever it suits you, and then there are the group meetings where that's a specific time, and then there's some assignments where you get personal feedback, but also asynchronous. So
awesome, very cool. I can put that if you have the link or anything, you can send me, and then I can put on the show notes so people can look it up. Awesome.
Yeah, we're not there yet with that, but as soon as we get it, I will be sure to send you the link.
Awesome. Okay. So let's transition to the final questions. Favorite resource of information? Are there any books, papers, studies, anything that you like in particular?
As to physical therapy in general, or chronic pain?
Doesn't matter, whatever you think it's valuable to share.
PubMed I usually go to, and then I have some colleagues that are really science nerds. So if there's something that I'm thinking, what could is there any literature on there? I usually drop them a line. I used to be a lot on Twitter, but I kind of got fed up with the tone on Twitter. I decided it's just not really a nice place, so I gave up on that. If I'm just looking for inspiration, sometimes I use Google Scholar. But other than that, my network of those really resourceful people.
Yeah, awesome. And what would be the best advice you give to clinicians that are starting their careers?
Well, for me, I think the game changer was when I got away from the passive and into MDT. And doing the diploma really gave me a structured way of assessing information and also incorporated it into daily practice. Maybe I'm partial because I'm a member of the faculty of the McKenzie Institute, but I definitely think that's a good way to go. And also read articles and be critical of them. But also try to incorporate new stuff into the way you work and be creative, especially if you work with the chronic pain patients.
Yeah, awesome. And any qualities, personal qualities or abilities that you think are important to become a successful PT?
I think you should have empathy. And if you work with the chronic pain patients, you should definitely also have what we in Denmark call the therapeutic code, which means that people will give you their stories, which are filled with pain and misery, and if you take it all in, it'll be too tough on you. So be empathic, but also take off the therapeutic coat when you go home and go out and have fun with people that you enjoy being with. But I think empathy would probably... An interesting study, though, was that I discussed with the psychologist at the pain clinic. They showed that if you have empathy and you give patients a lot of empathy, they will end up being worse. If you have no empathy, the patients will end up coming to your clinic. So the main line is that you should be empathic to the point where people realize that you are trying to help them. And after that, you should become factual. An example could be, let's say that you have a patient that is a boom buster and they need to stop booming or busting. They need to stop doing all the chores. And you say, well, this is happening. This is what happens when you do it. And they kind of start complaining about, well, you can't do that and I can't do that. And who will do the cooking? And said, look, I'm not trying to give you a hard time, but this is the result that you get. So I'm not trying to be an ass or a dick about it, but this is what happens if you do that. Said, well, I don't feel, and could you? Said, I can't, but you can. And if you want to, I'll be happy to assist you. But instead of saying, well, it's too, yeah, that's sorry for you. And do you think you can get anyone to help? Kind of pull back and say, well, I'm just lining up the consequences of the life you lead. If you want me to help you change them, I'll be happy to do that, but you're going to do the work. I'm just going to tell you which direction to work in. So that was one of the things that we did, because apparently giving too much empathy kind of gets people into becoming more of a victim. Said, well, it's so sorry for me. Yeah, it's so sorry for you. So basically, it is sorry for you, but what are you going to do about it?
Yeah, be practical about a solution so they see why they are there. Yeah, makes sense. I think that population is a little different.
And one more thing, if you do start working with chronic pain patients in that group of patients that I talked about today, make sure to have tissues at hand.
Oh, I just imagine how tough, like, you are all day long just listening to sad stories and people in the worst time of their lives. Being able to just take out the code, I think that's hard. At some point, you just like get tired of listening to people complaining.
One of the things that I discovered when I switched from the pain clinic to my own clinic, I did that part-time at the pain clinic and at my own clinic part-time in the beginning. And it was that it is really tough, because it's hard listening to, I wouldn't call it complaining, but people being at a very tough spot in their life and listening to that all the time, all day long. Yeah. And when you get to the point where you think, oh, she's complaining again, that's when you need a break, because your cup of empathy is empty.
Yes.
And one of the things that I see now in my own clinic, I still have these patients, but I don't have as many as I did when I worked full-time at the pain clinic. And my balance, you get the acute ones go, oh, my blah, blah, and you go, oh, directional preference, off you go. And they go, yeah, you're fantastic. And then you have the chronic pain patients where you work much longer for other results. But some of them are really, really gratifying. For some of them, you change their lives, and that's always a good day.
You have a few winnings through the day to keep you going with the easy derangements.
Yeah, make sure to keep a good balance in your own life.
Yes, absolutely. Oh, that's awesome. Anything else, Simon, that you want to add?
No, I would say strive to be a good physio on a bad day.
Yeah, it's tough. Well, I appreciate so much you taking the time to share your knowledge with us. That's a very, challenging topic, because it's a difficult population to work with, and a lot of times we don't know what to do. So I think you gave a lot of valuable tips and things that we can try to do with those patients. So thank you so much.
You're welcome.